Dr. Akshay NAIR who is an authority again in orbit and orbital surgeries. Uh, Please, Dr.
Thank
Akshay.
you. So I'll be presenting this challenging case of the orbit. Before I go into the case of orbital fracture, I thought I'll just have a few I have no financial disclosures relevant to this. A practical classification, I know the guru of classifications of orbital fractures is on one of our panelists, Dr. Ganga. So we know that there is you have the blow-in and the blow-out where only the orbital walls are involved without the frame or the outer network, the frame that holds the orbital rim is uninvolved. Then you have OZM or orbitozygomatic fractures where the impact is on the cheek or the malar area, which results in the zygoma and the orbit being fractured. And in cases where the trauma is directed to the upper half of the face, typically between the eyes on the nose, you end up with naso-orbitoethmoidal or NOE fractures, which are typically very complex to treat. And then finally, the worst of them all is where all of these involved, where you have comminuted orbital walls of all the four walls. So it's difficult to, you need to be able to understand the mechanics of the trauma that result in the type of fracture. And whenever you look at treating a fracture or holding the bones together, you look for an implant that is going to help in reduction of the fracture as well as healing without inciting inflammation or foreign body granuloma. So you're looking for stability, you're looking for malleability which you can contour and handle the implant well. It should be biologically inert or at least less inflammatory. And accessibility is an issue, so you cannot, some of the implants are prohibitively expensive, so ideally this should be what should fit in. And based on the type of implants that we have bioresorbable, like PLLG or osteomesh, which over time get resorbed into the body. You have titanium implants, which provide immediate metallic structural integrity. Biointegrable implants, where they do not dissolve, but allow the pores allow vascularization or biological integration of these implants. And of course, then you have a mix of both, like hybrid implants, titanium implant with Titan implant, which is titanium plus the biointegrable implant component. So bioresorbable facilitate natural bone growth as compared to biointegrable that bonds with the living tissue. Titanium typically is one that ticks all the boxes because it is non-toxic, it integrates with tissue, and it is resistant to corrosion. Another option is, of course, to harvest bone from the patient themselves and use that as a scaffold to bridge the fracture. And now you have PEEK implants, which are thermoplastic, they're biocompatible, and they can be screwed in any case, not just the typical holes that are being provided. And they are also now can be customized to the patient's fracture. So based on this background, now we go into this patient who is a 42-year-old male. He had a facial trauma. He was on board a ship as an employee where there was a hydraulic pump that flew open. And in this case, the impact was over the eye and the cheek. He had a primary repair done elsewhere. His right eye vision was 618. He had diplopia because the right eye was that should have been exotropia, not exophthalmos. And his concern was cosmesis, and of course he also had a concurrent post-traumatic fifth and sixth nerve palsy. Now, if you look at imaging, we can see that on the coronal slices, the medial wall of the orbit is absent. It is pushed in. The medial rectus is in the ethmoidal sinus. As you see posteriorly, the floor is also missing with the inferior rectus hanging down into the maxillary sinus. On the axial slices, you can see that there's a defect on the lateral wall, and on the parasagittal slices, you can appreciate the floor defect as well. So he had been, operated elsewhere, but only the framework was put in place. The walls themselves were left. So there was a medial wall defect, there was a floor defect, and a lateral wall defect. Now, based on all the implants that are available, it would be difficult to mix and match. So in this case, we decided to go ahead with what is now a patient-specific implant. In this case, we take the CT scan images, which are 0.625 mm over the DICOM viewer, and use that, the normal side or the unaffected side, which is superimposed over the affected side, and then that is used as a template. So keeping this template in mind, so now in this video you can see that the yellow outline that we've taken is the mirror image of the normal side. And using that template, if you were to create an implant, you can see this blue line that you see inside. That is where the wall should have been, but instead the orbital wall is somewhere inside here pushed in. So an implant would have to be placed over here as well as to cover the defect of the lateral wall. Now, this is only on the axial slices. As we go forward, we can see the implant has to be fairly large to address all of the defects that we see. And on here again, you can see that the floor is absent. So what we see here is where the implant should be. Again, the maxillary sinus, the floor has opened up into the maxillary sinus. And similarly, we can see on the sagittal slices as well that the floor is completely defective, and this huge defect has to be replaced. So based on this, if you see also a volumetric analysis, because of the loss of the walls of the orbit, the volume of that orbit on the right side is 32 cubic centimeters as compared to the normal of 26. So based on the mirrored template of the normal side, if we were to place an implant, that would be the shape of the implant along with the fixation points. And if we were to now calculate the volume of the orbit, it would be symmetrical. But this is what the biomedical engineers would give us. And you can imagine how difficult it would be to place an implant of this shape into the orbit. So that's where we need to work together with them. And we can help them design two separate implants that could gridlock into each other, along with a fixation over the rim. And based on that, that is what they do. So they essentially 3D print the patient's skull. And then with that in mind, they would create these titanium implants that fit in together. And we were able to use these implants in the patient and fix the defects in all the three walls. And you can see post-operatively, the medial wall, the floor, the lateral wall have been addressed adequately. 3D reconstruction, Dr. Ganga, post-op imaging has been done for a change. And his motility defect, especially of course because of his traumatic six-nerve palsy, persisted. So we ended up offering squint surgery. He declined, so he did, however, get medial rectus botulinum toxin injection done. And this is the final outcome at 6 months. So he's definitely improved cosmetically, and he's able to maintain in straight gaze, no diplopia. PSI earlier, would have been an unthinkable thing, but this breakthrough is now very accessible. It allows customized care in unusual secondary scenarios with extremely satisfactory outcomes. And additionally, this has now become very economical and truly changed the way we treat orbital trauma. Thank you for your time.
Thank you. Can you still keep the slides on?
Sure.
So by your own definition of the classification for the benefit of the audience, based on the scan, can you get the slides on, please? What is the type of fracture that you have, number one?
I think I should change the label of faculty to student. That always happens when Dr. Ganga
No, you're educating the crowd. Just going back to the preoperative scan.
Right.
Yes.
So this would be if you were to look at this scan alone, let me pull that up.
This is very important because sometimes even before we manage these patients, you want to get the diagnosis right.
So this,
like any other condition.
And knowing that he's already had a primary repair done, this would be the fourth variety, because he's got the rim involved, he's got the lateral wall, medial wall, and the floor comminuted fractures. So
Precisely. That's the point. Go to the coronal and sagittal, the CT scan. Yeah. So that's the point we're trying to get across as well. This is a complex fracture. And if you look at even the orbital roof that was not mentioned, you can see it's not the bone window, there's a soft tissue window. You can see the roof is also displaced. So the problem here is a volume issue, where the entire volume is expanded on that side, whereas the content of the orbit is still the same. same globe, same fat, same muscles, whatever it is. So the enophthalmos, the exophthalmos he had actually was an enophthalmos, in addition to the complex things that is had. So the first step towards managing these patients is get your diagnosis right. Do not read the reports, read the scans, unless there's a radiologist in the crowd. We read only scans, we don't read reports. If you were managing the patient, again for the benefit of the audience, the first time, what would you have done different? And I think that's a point we want to learn from these kind of challenging cases.
So the first thing is that, one of the things that often we end up missing is, we call it, we used to learn it in medical school, open reduction internal fixation. But sometimes we see scans like this where it is only open fixation because there is no reduction happening. So the 3-point fixation is important to be able to get the zygoma, the maxilla, the orbital rim in position. And at the same time, it is possible to tackle the walls as well. And so the thing that was possibly missed at the first time is to not address the medial wall and the floor. And that should have been done at the same time. So this could have been done even without a customized implant at the primary sitting, where we could have put in a titanium.
So the mistake I see is there was no ophthalmologist involved in the primary reconstruction.
This was done by maxillofacial.
That's the message I want to get across again. There's a breed of ophthalmologists called oculoplastic surgeons. We are a subspecies, right? Within ophthalmology, our residency programs do not quite train us to be good orbital surgeons. I think they should be part of these teams, and that's a message I want to try to get across. Sunil, over to you.
So there are 2 points I would put in based on what my experiences have been. There are times when I put in extensive implants like this, worrying about the volume and the volumetric symmetry, and I have forgotten about the optic nerve. And maybe these fractures are such that they opened up the orbit to allow for, so there's some divine powers which are saving the optic nerve and not allowing it to go into orbital compression syndrome for the optic nerve. So keeping in mind that optic nerve is something. So we are probably traumatologists who are pan-traumatologists. So we are not just oculoplastic surgeons, we are also neuro-ophthalmologists. So keeping that in mind, I think they've done an excellent job. Second thing is that the possibility of a CSF leak, I have faced a CSF leak when I opened it a second time. So you really want to see whether that roof is really healed and not leaking anything. Because you get a CSF rhinorrhea which was not there because of a clot. You dislodge the clot and the CSF rhinorrhea comes in. And the third thing is over a long term, when you look at enophthalmos, such an extensive injury will invariably have what is called as a subsequent fat atrophy. So your contents and things, you are think that this is the X volume of the content. Over a period of time, that volume of the fat is going to reduce. So you made an excellent thing. You did it exactly like the other eye. But we did not keep in mind the extrapolation of the fat atrophy that is expected. So when you put that into the picture, you will probably want it to be a little smaller, but keeping in mind the optic now. So those are the 3 points which I have. So I have done a perfect job, and at the end of it, there's still an ophthalmos at the end of 2 years. And I was like, what happened? I mean, when I see the orbital volumetry, so they've done an excellent job. So when you see the post-operative imaging, I also would want to know the post-operative volumetric compared to the pre-operative. And then your post-operative volumetric is the same as the other eye, but still you have an ophthalmos. That's when there is a fat atrophy.
I must compliment you for excellent presentation and making about these 3D images. It's a very good concept. I've been very active orbital surgeon way back in 1990 to 2014 regularly. And
was not born at that
seen
time.
that what we have mentioned, that initially it was only we as an orbit surgeon, we have been taking all orbit and trauma cases in there. Later on, we started having the reconstructive surgeons, they entered neurosurgeons, and then we have the subspecialty of maxillofacial surgeons right from the ENT and the dental. So now it is a teamwork. Our aim is not a solo game, but to give a patient best of aesthetic and functional outcome. So for that, as we have mentioned, we have to act as a part of a team and take help of everyone or assist them. It is essential for the patient as well as this coming up the CPCs and all other litigations. There also it will be very important that you have consulted. Thank you very much for such a wonderful presentation. May I invite our dynamic speaker, Dr. Shreya Shah?
Dynamic speaker, dynamic surgeon, and a yoga expert.
Can you connect? Extraocular muscles. Extraocular muscles.
So while she's connecting, one of the things we talk about is when you have a patient with fracture, unlike an open globe injury, I tell the patients you're a lucky guy. Like he said, Dr. Sunil Morike said that when the orbital bones break, they are nature's shock absorbers. By absorbing the impact of the forces and crumbling under pressure, they're protecting the two vital structures, the brain and the eyeball. So for every single open globe injury that you all manage, there are probably 15 to 20 fractures that we're seeing as part of an ophthalmic trauma that we fail to address. So I tell my patients, you're a lucky guy, and we can fix these with very minimum morbidity.
Thanks for pointing that out about the brain, because I am one person who's had 12 head injuries and 1 orbital injury. And during the orbital injury, as a oculoplastic surgeon, I was very concerned about the orbit, missing the point that I also had a traumatic brain injury. So these traumatic brain injuries or injuries at the occipital lobe and all will eventually cause a retinal nerve fiber retrograde degeneration and some loss of fibers. That is something. So traumatic glaucoma as a reserve loss glaucoma because of a TBI. So the way you all guys are going with the trauma societies, APOTS and all this is amazing, because you're considering everything, even the traumatic brain injury. And thanks for bringing that point up. So I had to.
I'm at the pace of grade